evening, one and all. I am Dr. Amit Nikose from MQR Pharmaceuticals, Pune. So I welcome you all for a scientific program organized by DGF on MA. MA is nothing but Movement Against Anemia on Thursday, 20 December 2021. Take the agenda ahead. Let me take this opportunity to welcome and introduce Dr. Jyoti Bhaskar, today's program coordinator. Madam is a principal consultant Ops and Gynae at Apollo Cradle Hospital, Delhi. Madam is also president of DGF, co-chairperson AOGD, subcommittee on quality improvement, secretary of Delhi chapter of Indian Menopausal Society, executive member NARCHI, member representative of RCOG GNZ in RCOG UK. So with this, now I'm handing over to Dr. Jyoti Bhaskar, madam. Madam, over to you for further proceedings of the meeting.
Thank you so much, Dr. Amit. And with that, I extend a warm welcome to each one of you who are here today, this evening, on a very cold evening, as Dr. Dipika said. So we are going to be today having this particular webinar with the main aim, and that aim is to have an anemia-free India. And when I had joined Dr. Jain in 2010, that is the time I said that she has been fighting, and she has really put in so much of an effort in life to have this anemia-free India. And today, again, we start as a pan-Indian program, a movement against anemia. The main motivating factor, again, to bring this out to the forefront is the NFH's report 5, which was just published in 2021. As many as this report has been very stunning, and to some extent, it's been very unfortunate to know that despite so many years of our fight against anemia, we have about 68.4% children and 6.4% women who have been surveyed. They were found to be suffering from anemia. And this has been a rise from the 2015 report. India ranks 170th among 180 countries where women are suffering from anemia. And in the past 2 decades, the prevalence of anemia among Indian women of reproductive age group is 20% more than the world average. In the world, 1 in 3 women is anemic. In our country, 1 in 2 women has been found to be anemic. And this is despite that multitude of national level schemes have been running, from the ICDS, NNAPP, Pradhan Nutrition Program, and the Anemia Mukt Program. It is time that each one of us, the obstetricians, we rethink, we reaffirm, and we repledge to work towards having an anemia-free India. And that is the main goal of today's webinar and the movement that we are going to take ahead as a pan-DG. So I would like to start by introducing the experts that we have today who shall further enlighten us and interact with each one of us. They are Dr.Sangeeta Gupta. She's a consultant and ex-HOD of Department of Ops and Gynae at the Hospital beside Tharapur. She's also the founder secretary of Delhi Gynecologist Forum and has held several positions of importance in the FOXI and AOGD. Asmita Rathore, Director, Professor and Head of Department of Azad Medical College. She's also the Vice President of DGF Dwarka. She has got several publications. She's been associated with very important positions with the AOGD as well as the RCOG. Dr. Aneja, who's the Director and Head of Minimal Access Surgery of Fortis. She's the President of Delhi Gynecologist Forum South and the Chairperson of AOGD Endometriosis Subcommittee. Dr. Shashi Kabra, who's the Senior Specialist of the Laksha Nodal Officer of Deen Dayal Upadhyaya Hospital. She is the President of the DGF South, and she is known for organizing more than 50 workshops on PPH. This, I now introduce and welcome our chairpersons for the 2 talks. I welcome Dr. Achla Batra, who is the President of AOGD. She is a professor at the Department of Obs and Gynae at Sharda Jain Hospital. She has immediate past president of NARCHI from 2018 and 20. She's been the chairperson of Urogynecological Committee of the AOGD. She has held several important positions as chairpersons and has been at the forefront for the AOGD as well as that for the NARCHI. She has got several papers to her credit. She has authored several books. She has really nurtured several students, and during her tenure, the AOGD has really shown a great growth. this particular year despite the COVID. Professor Dr. Dipika Deka is at present a senior consultant in the Fetal Medicine and Genetics Department of the Cloud9, the president of Delhi Gynecologist Forum, Dwarka. We all know her during her time as a professor and unit head of the institute, mainly the fetal medicine. She has really made a lot of path-breaking interventions in this particular field. She's been the director of AIMS at Kalyani with several publications and several awards to her credit. I now ask and request our chairperson, Dr. Achla Batra, to introduce our first speaker, Dr. Sharda Jain.
Thank you, Jyoti. Thank you for the kind words. And who am I to introduce Dr. Sharda Jain? I think everybody knows her. She's my teacher, everybody's teacher, I think. And I would just say she's a crusader. Whenever there is something, some cause to be taken up, I've always seen her as the first one to rise to it and take it, and then everybody follows. And anemia, like you rightly said, is a great problem in our country. In Southeast Asian countries, anemia is a problem. But 80% of the mortality of Southeast Asian countries from anemia is from India. So India really has to wake up and take us. Probably the maternal mortality and women, we have to take a stand for them, because when I was seeing the government program, they're all based on, ASHA workers doing this, ASHA workers distributing this, or the school teacher distributing. I think we have to take a very, very active role in now decreasing anemia, because from 2000 to 2015, there was a 1% fall. And now you're telling me there's a 3% rise since then, which is really difficult to take it, since there are so many programs going on, Bharat, Anemia Mukt Bharat and Anemia Andolan 6x6x6. So I think there is something wrong somewhere, and I think it is we who have to wake up, rise to the occasion and do something about it, to decrease this anemia. And the most common cause is iron deficiency and other nutritional. But we also have this another non-nutrition related anemias, which are also very prevalent in our country with hemoglobinopathies. I think today's webinar is very pertinent, in which we are going to talk about the nutritional anemia as well as thalassemia, which is preventable disease, in the sense that we can prevent the thalassemia children from being, such children being born who have to suffer so much in their life. So I think today's webinar is going to wake everybody up and start doing something. And welcome Dr. Arora. I have known him, as a crusader for thalassemia for so many years. I always see him doing something. So thank you very much for making me part of this program, and welcome Dr. Sharda Jain.
You'll give me a second. Let me just share my presentation. I think I always say when the stalwarts speak, they have a small message but a very deep message, and I'm very thankful at the outset to Dr. Arora that he also decided that he will consented that he will speak. He said, even on thalassemia, if you want me in the middle of the night to speak, I'm ready to speak. So this is the zeal and the zanoon should be there for things. If somebody asks me, what is the USP, health USP of India as a gynecologist, what I look at it? I feel this is a land of anemia and malnutrition. And anemia and malnutrition are the two sides of the same coin. Anemia is very easy to pick up and treat and eradicate. I'm a firm believer for this. And this is the message I wish to give. This is the focus area for myself to work on this for the next 5 years now. And this is a learning objective and a learning point for you all also. Now, I've titled it again, focusing on 12-gram hemoglobin for children, girls, women in India. And this is the need of today. 2021 National Family Health Survey is out, and this is out on 24th of November, 2021. And very disturbing finding. Anemia's prevalence across age and gender groups has increased by 2 to 9% among children, among adolescent, pregnant women, and even men. And as I said, this data was out on 24th of November 2021. The children who are born in rural area, the incidence is around 68%. These newborns are anemic. And in urban area, this incidence is slightly lower, which is 64%, while in a rural area, the incidence is slightly more. Alarming picture, close to almost 65 to 70% children are anemic. Now look at the children from 6 months to 5 years old. Now it is 67% compared to 58% in NH, National Family Health Survey 4. Great increase of almost 9%. And again, rural areas impact is little more than urban areas. Again, the difference remains the same, 9%. This is the highest group where the difference is there. The second highest increase is recorded for adolescent girls, where it has risen from 54% to 59%. Again, there is a difference between a rural and urban divide. In rural areas, what about women? All women between ages between 15 to 49 reported a 4% increase in the incidence, and it is up from 53% to 57% now. Pregnancy, it has increased from 50% to 52.2%. The men, they have divided again into elder men and the younger boys. Younger boys more than 12 years of age. In younger boys, they found nearly 1/3 of them are still anemic. Again, they have shown a rise from survey 4 to survey 5. And elder men, from 23%, it has gone to 25%. As we all know, anemia and malnutrition have remained a big problem, public health problem with us. I'm not going to talk about 1 billion people in the world which are anemic, but I'm going to talk about ourselves. It's a cause of concern. This particular slide is almost 25 years old, which I used in my first presentation in 2000, when I made the first presentation in IMA National Conference. Whenever there is a mild anemia also, there is a tissue iron deficiency of iron. And this affects very badly our work performance. And that's why India is called the lazy race. Chinese जिस काम को 2 लोग करते हैं, हमारे को 10 लोग को काम करने की जरूरत पड़ती है. So we can never compare. We all know, and that's a message I've been trying to do it from the last 21 years, that child's IQ is determined by the hemoglobin of the mother during pregnancy. I repeat again. IQ of the child is decided by the hemoglobin level of the mother. And that's my trump card. I tell them, look, your hemoglobin is low and your baby is going to have a less IQ. अब सोच लीजिए आपने उसको चपरासी बनाना है कि अब्दुल कलाम बनाना है. And then I find that the ball is in their court. हर बार वो बोलेंगे डॉक्टर साहब आपने मेरा हीमोग्लोबिन नहीं कराया. डॉक्टर साहब देखो मैं बहुत कोशिश कर रही हूँ. And this is what each one of us have to do it. If the IQ is going to be less, the school performance is going to be less, and we know it, child development, 50% of our people are stunted, irrespective of the gender. हम कैसी रेस ला रहे हैं? चाइना में हम सोचते थे ठिगने लोग हैं, वो अब 6 feet tall है. And reverse is happening with us. Unless each one of us becomes sensitive about school performance of the child, which is related to the IQ, and they're indirectly related to the hemoglobin of the mother during the pregnancy, the child development performance, and making our race ferocious race, जिसको कोई हमें आलसी नहीं करे. And whenever the anemia is moderate to severe, we all know that increases the child mortality, maternal mortality, perinatal mortality. I'm not going to get into detail of that. Now, the WHO says, एक बच्ची 2 साल की है और एक बच्चा जो 2 साल का है. During adolescent, throughout her non-pregnant woman, till the time she dies, her hemoglobin shall never be less than 12 gram%. So 2 साल से लेकर मेरी जैसी महिला क्या हीमोग्लोबिन कभी भी 12 से कम नहीं होना चाहिए. So जब भी 12 से कम हो आपके कान खड़े हो जाने चाहिए कि as a Hindustani doctor, what am I doing for my population? We all know that the oxygen carrying capacity lies with the hemoglobin. ये hemoglobin ठीक रहेगा तो जो ब्रेन को 20% ऑक्सीजन चाहिए वो तभी पहुंच पाएगी अगर मेरा hemoglobin ठीक है. So this basic things need to be remembered. I'm not talking science now. I'm talking very practical things. Whenever there is anemia, we all know it decreases the hemoglobin and decreases the iron oxygen carrying capacity of the blood. As a gynecologist, I come down to pregnancy. WHO says that by the end of the pregnancy, the cutoff is 11. As an Indian doctor should aim at 12 gram in pregnancy too, in case if you want to save the life as a result of PPH or any hemorrhage. अगर लेडी का हीमोग्लोबिन ठीक नहीं होगा, the impact of PPH झेल नहीं पाएगी. I only take my example. If my patient's hemoglobin can be 12 gram% at the end of the pregnancy, in almost every patient, then why can't anybody else do it? That's the question I always ask. These are the figures of 2002. India stood tallest as far as the anemia is concerned in comparison to neighboring countries. Good 89%. And now you see the latest survey of 2021. And I'm comparing it with the survey of 2015 and 16. The overall incidence was 53%, and now it has gone to 55%. In pregnancy, it has gone from 50% to 52.5%, and non-pregnant patient from 53% to 57%. We've come a long way from 2000, where it was 90%, and we have come down to 52% now. We've come a long way. But increase of anemia by 4 to 9% in 2021 census is unacceptable. It means we have not prioritized it. We derailed हो गए, हमें पता नहीं कहाँ हमारा focus होना चाहिए. I again repeat, अगर हमारी नींव इतनी कमजोर होगी जिसका हीमोग्लोबिन कम है, जो स्टंटेड है, उस कंट्री का क्या होगा? Each one of us whether we are doctors, whether we are nurses, whether paramedics, everybody, every parent should be obsessed with the hemoglobin of 12 gram percent. Magnitude, 20% direct maternal deaths. And I always say, very easily it can be picked up and very easily it can be eradicated. I've been working on this particular aspect for quite some time, but I think kahin to chook hoi gayi hai. Few facts. In front of stalwarts, I don't have to say that 20% of direct deaths and 20% indirect deaths, maternal anemia is the cause. But nothing is more expensive than missed opportunity to treat these patients when they come in contact with the doctors. For every death, disability is seen in good 30 people. For almost dead because of this severe anemia and moderate anemia. I don't have to enlist, I have to only come to the physiological aspect of anemia. Get obsessed about the infant hemoglobin, child's hemoglobin, adolescent hemoglobin, and pregnant patients and a non-pregnant patient hemoglobin. I repeat again. 2 साल से लेकर जब तक हम मरते नहीं है हमारा हीमोग्लोबिन 12 से कम नहीं होना चाहिए और बॉयज का 12 साल की उम्र के बाद 13 ग्राम हीमोग्लोबिन होना चाहिए अगर उससे कम है तो सोचो कहीं थैलेसीमिया तो नहीं कहीं और प्रॉब्लम तो नहीं all that negative problems will come, we'll look at into it. तो कान खड़े हो जाना चाहिए as far as the hemoglobin is concerned. On the diagnosis, I will say, I think this august body who are listening me, they all know about the symptoms of anemia. I can definitely say that आपको tiredness जल्दी हो जाती है. आज मेरे पास time कम है, तो इसलिए I'm not going to talk in detail about it. ये hair fall भी can be a sign of the same thing. I don't have to dilate on this particular aspect, but I will say that order only those investigations which you can interpret and have a clinical relevance. So I'm going to touch upon it. Few things will be touched upon by Dr. Arora. I'm not going to dilate on that particular aspect. जब भी हम investigation भेजें, CBC with peripheral blood smear, we must send. आजकल एक फैशन हो गया कि पेरिफेरल ब्लड स्मीयर्स omit कर देते हैं. This should not be omitted. Urine and stool examination in case you find significant anemia is there, and जो भी antenatal investigations होंगी उसको तो आप कराएंगे. These 3 things are very, very important. In fact, every parameters of CBC is each doctor should know how to interpret it. Roughly, I can say hemoglobin and PCV ka relation is 1:3. If the hemoglobin is 10, the PCV has to be 30, and the PCV is more reliable than hemoglobin. Peripheral blood smear is very important for us to know the abnormal cells, the parasites, and the diagnosis of the type of anemia. Reticulocyte count, we all know that it gives us clue the way the bone marrow is responding. I'm very fond of telling that from CBC, every doctor should be able to interpret, every nurse should be able to interpret by Mensa index. That is MCV divided by RBC. If it is less than 14, it is thalassemia. If it is less than, more than 14, it is iron deficiency anemia. Sir is going to dilate more on this, Dr. Arora. And this is what it is I'm trying to show in this particular slide. So whenever you are investigating cases of anemia, do a complete blood count and all this importance is there. What I wish to emphasize to you is serum iron, TIBC are unreliable markers. Serum iron shows diurnal variation and is affected by dietary influences. And that is why, and in pregnancy, the TIBC gets increased. So even in the absence of iron deficiency anemia, you find this factor is increased. So not routinely, you should recommend serum iron, TIBC, only when the serum ferritin is normal, but clinical and morphological strongly suggest iron deficiency anemia. Now this slide is very important. When your hemoglobin is more than 12 gram percent, that shows that the storage iron is full and the transport and functional iron is also there. When iron gets depleted, it means you are at the level of 12 gram%, and further it goes down 11, 10, 9. It shows that your stores are all depleted. And even your transport and the functional iron also becomes less. So whenever you are going to treat your patients, you have to see to it, you have to keep a margin of 4 to 5 months to complete and restore the storage. As for the management of iron deficiency anemia is concerned, we all know about it. मुझे ये example बहुत बढ़िया लगता है, मेथी का पराठा बनाना. So iron and जो भी hematinic supplements हैं, they work like a methi. But अगर आपने hemoglobin component बनाना है, तो diet को look after करना पड़ेगा, उसका protein component को look after करना पड़ेगा. And that each one of us should definitely know that and guide them accordingly, that green leafy vegetables and other things are very, very important. This is the great slide and which shows the sources of iron and the sources of folic acid. We all know that the folic acid does not have any reserve. I don't have to tell this August gathering all about this. WHO says that as far as parasitic infection is concerned, antihistaminic treatment, even in a pregnancy after 12 weeks, can be safely given. As for the management comes, this particular presentation is a repeat presentation of mine during this year. I had presented it 6 months back again. And I'm back again here that the absorption is maximum in iron deficiency anemia when you use iron ascorbate. It is the tune of almost 70%. This study has been a PRIDE study, showed it was an open-ended randomized comparative trial of showing what is the difference between ferrous ascorbate versus carbonyl iron, and they found that during the 60 days time when the treatment was given, the increase was noted of 5 gram per deciliter in comparison to 2.8 in the other iron group. So significantly more patients became non-anemic by the treatment of ferrous ascorbate in comparison to the other preparations. So this slide, I want each one of you to register in your mind that in 60 days, if you use the right preparation, you can find good results are there. 5 gram increase in hemoglobin in 60 days time. This is another HERS trial, which again also showed that they had taken a cutoff of 45 days and the rise in the hemoglobin was found in 3.6 per deciliter. This is often quoted in many of the journals and the books. Now let's compare other iron salts with ferrous ascorbate. Here I wish to just tell you that it is the right ratio has to be there. For iron, if it is 1, then the ascorbic acid has to be 6.3. If it is a low content of iron, high ascorbic acid, again it is less efficacious. If there's a high content of a free iron and a low ascorbic acid, again, you'll find it will not be tolerated. So the right ratio of the iron and ascorbic acid is necessary to form stable ferrous ascorbate complex, yielding high efficacy and favorable tolerability. Now, this is a British pharmacopoeia which shows the comparison of ferrous ascorbate with other drugs. No salt is in comparison to this particular combination. I wish to emphasize again the non-nutritional factor of anemia. Whenever there's an accelerated growth, we need to see that anemia does not seep in. Loss of blood in case of heavy menstrual bleeding, the people have it, will definitely have anemia. And we gauge the severity of bleeding by hemoglobin level. Same way, loss of blood during postpartum period also makes her anemic unless supplementation of iron is given. And we all have just now said the infection with malaria, hookworm infestation, also a unique thing is there as far as our country is concerned. And teenage marriage and early pregnancy again lands her in anemia. As far as the bleeding is concerned, we all know about it, that in perimenopausal age group, nearly 50% have problem, adolescent 30%, and in reproductive age, 30% have problem of heavy menstrual bleeding. In India, the reported incidence is 20%. And we find nearly 50% of the gynae OPD consultations are because of abnormal uterine bleeding, which is on the heavier side. As for the postpartum hemorrhage is concerned, we all know that in today's time, 2021, 25% of maternal mortality is caused by PPH. And if you want to eliminate, if you want to decrease maternal mortality, it is PPH and PPH which has to be prevented. And for that, we have to see to it that our patients, when they go into labor, the hemoglobin should be at least 11 gram%. A word about focus on tranexamic acid. I thought I will take an opportunity of talking about this. This is an antifibrinolytic agent. Indication is prevention and the treatment of hemorrhage due to because of local fibrinolysis, and the dose is recommended is 1 gram 2 times or 3 times a day. Its mechanism is that it is competitive inhibitor of plasminogen, and it inhibits both plasminogen activation and plasmin, and this leads to better stable clot is concerned. So this is the beauty about this particular salt is, again, the studies are many there in the literature. Whenever used in patients of heavy menstrual bleeding, we find that tranexamic acid, when we use it, there's a significant reduction in the pad count. There is, when you use this, 40% reduction is there in the menstrual blood loss. And as far as its use in cesarean section is concerned, for to decreasing postpartum blood losses, it is said that it can decrease to the tune of mean 160 milliliter blood loss becomes less. Lower incidence of PPH and the severe PPH, significantly lower drop in the hemoglobin level, and we suggest one must consider giving 1 gram of tranexamic acid 30 minutes prior to giving spinal anesthesia. I've been using it, and my suggestion is that people should use it. Now, there had been a large study on 21,000 women, and the sum up was that it is a very effective method, and 1 gram is the dose which need to be given prior to spinal anesthesia before doing a cesarean section. So this is WHO. Recommendations are that the death due to bleeding was significantly reduced in a woman given tranexamic acid, and the bleeding in the next 3 hours was also less. So the recommendation by WHO is that gynecologists should use this particular method to decrease it, and same American College of Obstetrician Gynecologists have also recommended it. So as for the new ways of treating is, I can say that the ferrous ascorbate, gynecologists should be conscious about it, that it has got a superior absorption, 4 times higher than the most other irons in iron deficiency anemia, and to manage, to decrease the incidence of PPH, tranexamic acid is a safe drug to reduce partly this thing. And at this particular time, I will say that now carbetocin has come for a prevention of PPH, and we should use it liberally. So with these words, thank you very much.
Sir, please unmute yourself.
Unmute, please unmute yourself.
Thank you, Dr. Jain. I think it was a very focused talk on anemia, and I think one should again reiterate that reading that hemogram which comes is very important. Just seeing a hemoglobin low does not always mean it is iron deficiency. You have very rightly pointed out that all the factors have to be looked: the PCV, MCV, the red cell weight, what is the RBC count. If you look at it carefully, you are able to diagnose most of the causes of anemia, whether it is iron deficiency or it is a dimorphic, which is more common in our country. And then starting the correct treatment will be, even if when the patient has come to you, if you just see the hemoglobin and start iron, that is also not right. You should look at the hemogram and then you make a decision what is to be given. That point is very nicely emphasized by you. And of course, the treatment has to be given once you make the correct diagnosis. Thank you.
Thank you so much for the question. Dr. Dipika, would you like to?
Yeah. It is now my proud privilege, after the very enlightening talk by Dr. Sharda Jain. I really agree that, deworming, I used to routinely give it. And now from that talk onwards, we come to another very specialized reason for anemia in our country. ICMR has said that the incidence of thalassemia minor is as high as 6 to 8% and in North India. So in fact, a little story, like I knew that my son would marry a Punjabi. So I said, the first thing you have to do is just get the thalassemia test. So I think we should make it a routine now to do a thalassemia screening. Not only that, there are many other hemoglobinopathies. Like for instance, in Assam, where I belong, hemoglobin E is very common. And in different parts of the country, other types of hemoglobin. And when mixed with thalassemia minor, can also. So we not only have thalassemia major, but we also have the other lesser hemoglobinopathies. And for all this, my initiation to thalassemia was thankfully to Dr. JS Arora. Dr. Arora, you remember, like almost 35 years back, I think we met. And since then, he has taken me to his doctor-patient meetings. Doctor-patient meetings where I have met the young children. I still remember one little boy, not so little, he was about 17, 18, and he said, Auntie, I do exercise like Salman Khan, but why are my muscles not like him? And then, they all go into some sort of depression, don't you think, Dr. Arora? They do have, and despite, of course, now things are better, but girls used to have amenorrhea. They never became pregnant. It was very interesting that very recently I had a girl, thalassemia major from Patna, who came to meet me in Cloud9 and wanted to be pregnant. She was put on OCPs by her local doctor for 15 years because she would otherwise bleed. And now I stopped her OCPs. Then she gets this very bright idea that she should have the pregnancy by surrogacy. Because being a thalassemia major and then having the anemia of pregnancy would be very dangerous for her. So she's now opting for surrogacy. So besides just thalassemia major, we have so many other things to discuss, Dr. Arora. You have to, of course, prenatal diagnosis is one very important thing which our obstetricians have to know. But also, if a thalassemia major becomes pregnant, if a thalassemia minor becomes pregnant, how do you manage? Whether to give iron, whether to give intramuscular, whether to give blood transfusion. These are some cobwebs which needs to be removed. So I'm very happy that the expert, Dr. Arora, who Achla said has been a crusader, I have seen with my own eyes, the way he totally has devoted his life to thalassemia major. I welcome Dr. JS Arora here to talk on the thalassemia prevention. Can I have his slide, please?
Yes.
Dr. Arora's introductory slide.